So we'll go ahead and get started. Before we go, I'll go ahead and call the panelists: Suhail Khan, Najib Azam, Sajid Dhakam, Hamid Sharif, Ahmed Noman, Fahim Jafri, Bilal Qureshi, Awar Kazmi, Kashif Hashmi, Dr. Ashok Seth, and Kashif Sheikh. So whoever is there, please either join us on the podium or virtually, please. So we'll go ahead and Umar get started with the first case.
Thank you very much for having us, Asad Patan. I will ask Adnan, who will present the case to you. Could you present the case, please?
Thank you, sir. We have a LAD CTO case. The patient is a 65-year-old male, has hypertension, diabetes, and hyperlipidemia. In 2006, he has RCA, PCI, and 9 months before, we treated his RCA, CTO, or PCI because the patient declined surgery. The electrocardiogram is within normal limits, no ischemic findings. The ejection fraction is 60%, and the laboratory is good. He presented with a fourth angina class 2, and today's plan is open LADTO. This is the electrocardiogram. It's sinus with no ischemic findings. So this is angiogram 9 months before, which we treated the RCA. Here we have LADCTO after diagonal 1, and there is a retrograde stent distal LAD from third collaterals. And this is dilation for RCA CTO, instant RCA CTO. Then with the RCA CTO, with Gaia 2 and antegradely, and we do dilatation. And after stent, the RCA looks good. And today, our plan is to open LAD. Thank you, sir.
Just remind us, when was this case done?
Okay. Did you see the patient, the case?
This RCA was done today?
No. RCA 9 months ago.
All right.
And we will show you the result. Could you go to the first image? Okay. This is the left system we have today. The circular good. We have LAD occlusion just after the big diagonal. Next, please. And somehow ipsilateral collateral here. Next. Not easy to see the proximal cap, but in one view, we that, and we have nice collateral from diagonal. And here, I will see that we have very good collateral from, I think it's come from OM. Ahmed, it's come from OM. Very nice collateral. And next, please. Next, please, yes. And now we have some right injection to see the right system. And stance, I like to see it. Okay. Now we see right coronary artery looks okay. We had implanted stent here 9 months ago. The result is excellent. Next, now we have some septals to go LAD, but in here, so we have iliac from antegrade. We have two options. First, there is epicardial one, and also we have septals from RCA. But of course, you know that septals from RCA easy. Sometimes we most probably try from OM to LAD, the LAD. Anyway, next please. We would like to show you where is the stump. It's not easy to guess it. Next please, in one view. Next please. In here, you see densification after diagonal. And between septals and diagonal, we have calcium. I think our wire
If we can see the, Omar, if we can see previous cine where it was epicranial with the bilateral injection,
Yes.
please, the previous one.
Okay. Come back, please. Sen tercüme et.
There was a previous injection, yes, this one.
Okay, this is bilateral injection. It's long, very long CTO, and we have this kind of proximal ambiguity. But in one view, I like to share with you, we see proximal cap. So that's why we first try to go integrate in this patient. Otherwise, we have nice collateral from OM. We should go through OM. Next, please. Yes. Next, please. So, if you come back, and the guided catheter was in the circ, you know, so when we tried to LAD, we just pull our guiding. We had the circ, so that circ hung our cath, but we failed to LAD in that maneuver. Next, please. So we tried to do it, but we failed. And what we do, we just push to have guiding to have direction to the LAD, and now it will, of course, to cross diagonal. Next, please. Next, please. Now, yes, we are here. See that we have proximal cap just diagonal, and we have a classification. We have the roots, I believe. The classification at least shows me where is the vessel. So I use I was guidance here. Can I?
So what wire do you have at the moment in the LED? Is it
in the LAD, in the diagonal, I have BMW, which was, yes, workhorse, yes. Now I'll insert IOS just to show you the proximal cap. But in practice, in this case, I don't think that the would help. I mean, I can see here, obviously, there is proximal cap, right? I don't know if you are agree with me, but for purpose to showing, you know, the proximal cap from the side branch, insert IOS, which is volcano. I mean, ring down, please. Ring down. So, could you see the IOS?
Yes, yes.
Okay. Record, yes, please.
Can I take some comments from the international panel? Fahim, you want to say something at this stage?
Yeah, I was going to ask, this is Fahim Jafri from Singapore. Out of interest in your practice, would you have done a CT before bringing this patient, the ambiguity of the cap? Or do you think that doesn't help you in your practice?
No, it's definitely help us for CT, yes. Sometimes we have CT angio, but it's not our routine practice. When we use, yes, it's a guiding, deep guiding. When we use, if we have failed CTO case, then we like to keen to have CT. Yes. In this patient, we don't have a CT, but obviously, if we could have, it's obviously will help us. Live upsana.
Suhail, you want to ask something at this stage?
Okay.
Hi,
okay. Just a second, guys.
Yes,
sorry.
Yes, Omar.
Now,
sorry,
I'd like
carry
to show
on.
you. Yeah, please. Sorry about that. I have some noise at background. What's that? In this patient, no, we don't have a CT, but obviously, if we could have, it's obviously will help us. I see my on voice.
I do need to mute some of your colleagues.
Suhail, you want to ask something?
Okay. Just a second, guys. Sorry. Ben bu durmak istemiyorum kendi sesimi. Sorry.
Yeah, we are okay now.
Okay, guys. Yes. If you look, the IOS now I'm diagonal. So how I know that I'm in the main vessel? I look to increase of the size of the vessel, right? Side branch obviously much smaller than main vessel. So I just see record, yes, please. Now I'm in diagonal. I believe I'm coming back, and you see you see that in 12 o'clock I have the CTO part. Just it's CTO. I see just the ostium, which is ostium is there. So at 12 o'clock I have now I'm in the main branch, right? So I push it, and at 12 o'clock I see the lumen. Obviously I see it as but mostly I see it as opacification, I would say. Okay. I think here is good to see my wire in good place. Leave it here.
Do you think that lumen is open, and on the angiogram you see a little nubbin?
Yes,
that is probably the proximal cap then, where you see some dye going in.
Actually, in one view, I have some, rim there. It is small right. Rim in one way. It was in this. Okay. Now I'm pushing my, which is fine cross, and inside I have BMW workhorse wire. Can you go to? Unfortunately, I have a not good.
What size guide is it? An 8 French guide, or what do you have?
This is 7 French. 7 French. We use it's good for many things.
You wanted to make a comment?
Yeah, thanks, Nadeem. Good to see you. So just a few things to say, really, and I think it's useful for the fellows as well. So just taking things back a step, what we're demonstrating here is a LAD CTO, an attempt to try and open up this LAD. This is a patient who's hugely from having this procedure done. We know that LAD CTOs offers ischemia, and this patient would have been in some difficulty with the RCA as well. Omar's done a fantastic job in trying to open up that coronary artery. Antegrade wire escalation is probably what I attempt here as well in this situation. And of course, we've got the benefit of having a huge diagonal branch in which we can put an IVUS catheter down. I didn't really get a sense how long the occlusion is, but what we did see is that there's a good landings, and the distal LAD looks of a reasonable caliber as well. So there are options here, but certainly antegrade wire escalation here, attempt with IVUS. Quick question for Omar, really. Do you think, are you happy that what you'll see is actually the LAD and not the septal? Because there is a large septum coming off there as well. So just want to make sure that you are actually aiming towards the diagonal.
Right. You. Sorry, I missed your question.
I'm saying that there's another branch that's coming off to diagonal. Are you happy that you're not just imaging into that other branch? Is actually the LAD ostium that you're seeing on the IVUS front?
Yes. Okay. Let's check it. It's easy to check when we give some injection. Now, yes, very good question. If I am there, let's see it now. Pull back a little bit, and I'm in. To me, I'm just in the junction. See, I was. Let's see. Good, give injection, please, Ahmed. So you see, I am a kind of just the occlusion, right? Yeah. So, yeah, here a little bit pull back. So I'm 100% sure that level is your level.
And which wire are you going to try and penetrate with?
I think, yeah, I can try the first of all, what I'm thinking, I could do many things, to be honest. But let's do, for penetration, I have a side branch. To penetration, let's use Conquest, 9. And it will be better for puncture, especially if you have side branch like this. And obviously, why I can't class this, guys? Let's remove. Yeah. Okay.
So, Umar, just for the fellows again and for our clearance, your workhorse wire is in the diagonal, and you put the IVUS on it to look at the stump of the LED. And Suhail was wondering whether that is the LED stump or whether your wire is in some other branch, or you're looking at the septal.
Right. I'm exactly the place where I see the, yeah, you see the, okay. Let's see now, where am I? And here I give some kind of curve. The tip of the, I give one CTO curve, and also now for, no, not supporting to go LED. Would you show us, please? Show me. No, bigger, please. More bigger. Bigger, my hand. On the hand. All right, I will do.
So have you put a secondary bend, Umar?
Yes. Okay.
Yeah.
Okay. I hope you see it. Yes. You see? 1 millimeter for the CTO.
Which wire is this, Umar?
This is Conquest. Yeah, this is Conquest, What I like to do, I like to do descalation if I could penetrate easily, and I like to have Gaia because it's long LED lesion. If it is short, Conquest is excellent wire.
So this is Conquest 9 or 12 or Conquest Pro?
This is 9.
Okay, Conquest 9. One of the panelists is asking Gaia 2, or why not Gaia 3? Why not Gaia?
You know why? Because I see some side branch there. So when you have side branch, it's nice to use a wire to penetrate easily. Otherwise, it may slip easily to side branch. That's the thing. But you can use Gaia 2nd, Gaia 3rd for the start. I don't know anything about that. It's possible, of course. I pull my. Yes.
Are you able to show the IVUS in the
IVUS olsun arkadaşlar. IVUS her zaman olsun. Yes.
That's great.
No,
if you flip them. So
you see the IVUS now.
That's good.
Pull my fan cross a little bit back, right, to search. And now try to go LED.
IVUS रख के वो कर रहे हैं जी नहीं clock wire is at 1 ये जो wire आ रही
Yeah. No, I think I'm engaging the but I sleep, I believe, no? I think I sleep there. Let's go to spider, maybe. Spider.
For the fellows, you can see the wire shadow at the place where Dr. Kotkin wants it on the IVUS.
I want to, my wire direction is on left side, rather than to diagonal.
So, I don't think it's unreasonable to go with a Gaia series of wires here, because not much calcification that we're seeing on the IVUS going into the LED.
I do penetration, and if you see my IVUS, it seems that I puncture in the good place. Let's see from the AP cranial, and to see my wire, looks better. I want to push my microcatheter slowly. If I was able to, yes, I push it. Now, I think it's time for Gaia, right? Because it's long CTO.
You can see on the IVUS what Dr. Gotkin was trying to do was to go in the middle of the rather than at the sides. If you go at the sides on the IVUS, you end up going subinter. The hope here is that he's going to be a true lumen here, but we'll find out very shortly if the guy goes.
Let's go to let's see first good injection from. I like to remove the IVUS to have the yes. Please inject now. See pistol of the lady. So it's very long way.
Is the wire moving freely there?
What do you mean freely? I push it, but I'm not sure where it's
micro.
It's the Gaia now, I guess.
Would you consider escalating at this point, maybe to an X-ray?
I don't know, where is it going, my friends? Okay, injection, please, let's see. It's a little bit easy, to be honest. When it goes easy, I push.
So, Omar, is this Gaia 2 or Gaia 3 or Gaia 1? Which Gaia are you?
Second.
Okay.
My Gaia now needs some support. I believe I am somehow in the vascular structure. So I like to push my pancreas to have better support because I...
Umar, because it's such a long occlusion, do you think it would have been to use a polymer jacket and either knuckle down, or since we're not sure of the wire, perhaps a pilot 200 would have been less likely to exit vessel versus Gaia Confianza?
Definitely you're right. You can, I mean, when I say right, yes, we got a 200 too. And, but I Gaia second, which is also a good option.
I mean, Omar, you've got your IVUS catheter there. Is there an argument for possibly taking out the fine cross and putting the IVUS down to see whether you're actually in the true lumen or not? Because the problem here is that if you're in the subintimal space and you're injecting contrast, then you're going to basically be expanding the space.
Course. Let's see, injection. Let's remove first let's remove IVUS that I can see better to distal. But I am not much happy about this Gaia, to be honest. Let's see.
And are there any collaterals coming from the right coronary that might be more helpful? Because you want to try and avoid doing any integrate injections here because you don't want to extend your subintimal space.
We have some septals, Suhail, but we don't see the distal of the vessel. Hold. Yes. That's fine. Okay.
Working. Anyone from the panel here wants to ask him anything?
Would you take a microcatheter?
I think it's either fine cross or Corsair.
Let's try again.
I think because it's such a long occlusion and the course is not clear, perhaps a upfront planned ADR strategy would probably be a safer option.
Very long occlusion. I am happy that I have retrograde option in this patient.
Umar, what's the downside of checking with an IVUS, removing your microcatheter and then an IVUS as Suhail suggested?
I don't think I could, yes, Nadim, I don't think I could easily. I'm not sure.
Right.
So,
it would be difficult to cross it actually.
Not easy to insert IVUS.
वो तो 1.5 से
So,
कर सकता है ना. अब तो इंटरमाथ तो कर दी, माइक्रोकैथेटर से ऑलरेडी lumen तो बना दिया ना उसने.
I don't know. Let's see.
Would you consider at this point
It is too much free.
to an XTA and see if it finds the microchannel?
Yeah, to me, I'd like to try pilot 200 here. And if it is goes subintima, most probably will go, but then I'll go retrograde. I don't want to waste that long conclusion. Better to do reverse cut here. Anyway, from the good side, I have a good, advantage now. We should do some.
I think
work.
One fellows and beginner operators that polymer jacket wires are much less to exit the vessel, so they're safer from that standpoint. So if you're not sure of the corsal, rather than take a stiff tip wire, it's probably safe with a polymer jacket wire.
Asad, can you line all the plastic jacket wires that we have on the inventory here?
I think just the Fielder XT series and Pilot 2, which I use. I think Boston has come up with other wires, which I'm not sure in Pakistan. So Pilot or Fielder X is better for knuckling versus Fielder XTA. So
I'm not happy at all. The course of my wire, right? I'm not happy as well. Let's leave my wire somewhere here and go retrograde.
If you have micro channels, Fielder XT might be a good choice, but I don't see a lot of micro channels here. So probably Gaia is not a bad choice to penetrate.
Okay, this is, I know that I'm not out of the vessel, right? And I have a chance now, I have a bit deep because with my micro, and I like to do distal pump, not with this wire. Okay.
I think just to clarify, for the Fielder XT would not be micro channels, but it would be a knuckling down with a planned integrate dissection strategy.
We are very close now.
You're in the architecture of the vessel here.
Yes, for sure.
Clearly not in the
yes.
lumen.
And I'd like to thank Asad. It's very good. Good comment that he asked Pilot 200. You know, as you see, it's better than Gaia for the proximal part. But now, I like to with the wire, I could send anywhere I want, which is Gaia or Miracle, for example, also. Sorry.
So which wire is this now?
Gaia, the first.
No, this is not Gaia. Is this Gaia? All right, okay.
This is Gaia?
No.
Okay, they said Gaia. We had Gaia second first. I asked for Gaia, I believe. Yes, please test.
I think it's important for the beginners, whichever stage of the CTO you are, you need to know what your wire has to do or what there is specific objectives. So either you're penetrating the cap or defining yours. So you need to keep changing wires depending on exactly what you need to achieve. You should not persist with the same wire and expect that it do the procedure for you.
So Omar, what's the harm if you are already want a penetration, and what's the harm in going for Conquest Pro 12 or something like that with hard, with a hard tip?
What's the aim, you mean?
What at this? Why not use a Conquest Pro 12?
I think, yeah.
For the penetration, because that will have the most penetration among the wires.
Yes, for the distal, I like much better Gaia series than Conquest to puncture distal, more helpful to me.
Okay.
concrete. But somehow I am in subintima. I still couldn't find it. I'm trying.
By a second again?
Yes, the new one, because the first Gaia seconds some curve. Now I'm straight one.
So Nadeem, to answer your question, yes, the penetrative wire will puncture the cap. If you persist and you're not sure where you're headed, you're just as likely to exit architecture, which is not what you're wanting to do.
All right. Yes, please. I don't like
I think the other thing about the Conquest is that the trackability and directionality is very, it'll basically puncture and go wherever it wants.
Here?
So once you have a wire, the Gaia series is much better.
Lastly, I try Miracle 6. If I fail, I go retrogradely. I have nice collateral, so I think I have chance for recanalization now. At least I have wire antegradely and I have good retrograde option.
Can you hear me?
Najib, I can see you. Can you have any at this stage? Najib Azam from UK.
I think Nadeem is I have got a lot of echo and repetition and slight difficulty understanding the operator. But I think overall, I think I was very impressed with the knowledge of tools and his ability to carry on.
Can you hear me? Najib, I can see you. Can you have any comments at this stage? Najib,
Ses bana sorudan geliyor, gelmesin.
Nadeem, something is I have got a lot of echo.
Yes, please.
नहीं वो दूसरी तरफ से इंजेक्ट कर रहा है ना, is not in the true loom.
I'm very far to lumen here. I like to redirect my wire from a little bit proxy and like this. All right. So from let's try another 2 seconds.
So which wire are you using now?
6 round.
Are you happy with the view, or like to change the view and see if it gives you more direction?
So far, not. I see that I am out of the. I am a little bit far from the lumen.
So do you fancy using a pilot or Gladius Mongo kind of wire for re-entry in this case? Integratedly?
You could use, but you know, with the more pilot, easily you could go distal. Now, I have no chance to maneuver wire. Okay.
So what we're seeing here is difficulty in trying to get back into the true lumen distally. So, you know, you've got a couple of options here. As you said, you could here with this technique, you could think about switching out to a dual lumen catheter and see if you can use a slightly different angled wire dual lumen to see if you can re-enter that way. Or you could think about dedicated dissection re-entry kits such as the Stingray device, see if you can use that.
Yeah, but Suhail, with such a long vision segment, do you fancy using cross-pulse and Stingray?
I mean, we'll end up losing branches, septals. There might be a couple of sizable diagonals coming off as well. But even if we now in the distal lumen using this particular wire escalation technique, we're going to lose those branches, aren't we? I mean, the only way to preserve those branches is to go retrograde.
Yes, the problem is that the distal vessel, I mean, when we see on the retrograde injection, So if you use crossbar stingray, we take a high risk of losing the side branches.
Yeah, absolutely.
But in this case, since you're not really seeing any branches filling up, it will be all occluded. So even I think if you manage to cross true to true, it's quite unlikely to perfuse the branches.
I mean, the other thing is, diagonal is a massive vessel, isn't it? And, I suspect there are any major diagonals coming off more distal to that.
I think retrogradely, if you try, I think there's a lesser chance of losing the side branch in retrograde. If you get this, the vessel, distal cap puncturing and going antigrade, retrograde might be a better option.
I think Omar is comfortable working in this view, but I would have to change the view a little bit to know how far or how close I am to that distal. But I think it's all operator dependent. If they're comfortable in one view, then that's fine.
I think, guys, I lost in that area, right? Many places I couldn't find the distal. From now, if I do work there, it's to me waste of time, right? So it's obvious, not easy to form distal Truman, even with parallel wire. It's long lesion. I don't want to do parallel wire technique here because I don't have nice, and it's long CTO. Let's do here, it's because it will be shorter than trying more antegrade.
So Umar, will you use a separate guide for the left, or you'll keep with the guide?
No. This is 7th branch, which is okay. And I will do ping-pong technique because I have right coronary. If I cross it, I will change my right coronary to EBU. I will do ping-pong.
Okay, yeah, that was the point.
So which wire have you got now?
This is BMW for searching the collateral.
Okay.
Can I have a test, guys, here?
Sorry, can you repeat that, Omar? Which wire?
BMW, this is for just to go side branch of the collateral. Yes. Okay. Here I have a nice code. So I push my microcatheter, and I'd like to ask Sion, please.
Would you on black or just the Sion?
No, Sion is enough. Yeah, good vessel. Let's do some typical. I can see it. I'm not sure. It's a big vessel. I may not see it.
So for the fellows, he's now decided to go retrograde collateral. So he's used a workhorse wire to reach the collateral catheter, and then he's now going for the surfing wire like Sion.
Looks like, I'm not sure. Let's see. Yeah, looks like the second one. In here, do you see here, guys? No. Show them.
It looks like it's the lower that top one, isn't it?
Yes. Have you seen it now, or?
Yes.
Yes.
Okay, good. I have a nice collateral.
So, Umar, going through epicardial, do you think a softer suho wire with a caravel would be a better option for wire and microcatheter?
No, fine cross is nice. Even here, it's tiny, so it aids microcatheter. I don't think any problem will happen with the Corsair here. Where is it going? As in terms of macro, let's see. For Sion, since it's not that tortuous, it's a bit not tortuous, right? So here also, I'm happy with the Sion. If it's tortuous, you are right. We can use Suo, especially atrial branch from. So we have to see clearly where is it, because obviously my wire didn't go. Let's see. Not this, the other one. Okay, frame by frame. Maybe it comes from another stud branch. but it's from here. Right? Very funny. Do you see
maybe
it now?
Umar, maybe it's a microcatheter and do a more selective injection.
No.
Change the view and see.
I think it's higher up than that.
Yeah, maybe this one, right?
Yes.
Suhail? Let's try. Yes, please. This one.
Yes.
Just for the beginners, Omar, made you decide to go epicardial, left-sided? Why not from from the right coronary through the septals?
I do tip injection here. Yes, because there are thousands of stairs, lots of, and they are, to me, a little bit tiny. Yes, of course, we can try. I believe this is easier than septals. And normally easier from right to LAD.
So in expert hands, there's not much difference between epicardial
I don't think there's a connection.
So
we have to see more better. Where does it come from, right? So
Nadeem,
yes.
Nadeem, even in expert hand, epicardial and septal or vein graft.
Let's see.
Right. Yeah.
Okay. Injection.
Right, I have to leave,
so
and Asad, do you mind taking as moderator?
Have you seen? Have you seen?
Sure.
This is wrong
Nadeem,
one.
go ahead.
This is wrong. Better now?
Yes, we do. So,
but you
Umar,
know, yes, but it's our mistake, to be honest. With the tip injection, you know, I don't see them, but I trust the other view. But I trust the tip injection. What do you think? Do you feel the same?
Yeah, and I think
Yes,
it's a nice
yes.
example of changing
Yes.
views
And also to trust injection. Okay, test please.
Dr. Omar, the time is actually over. Maybe we have cups, and I don't know.
Let's show you the crossing. Yeah, my friend, give me 5 minutes.
Okay, that's fine. I was thinking
let's show
otherwise
you
we are going to come
crossing.
back anyway. You can show us that. Fine, 5 minutes is okay.
Okay, thank you very much. Just give me 5 minutes. I will show you. Because after crossing this cage, maybe in short period, hopefully, of course. Okay, can I see where is it going now? Another one. Let's do more tip injection. Bu aynı açıya niye çalıştığımız açıya? Hayır. Aldığımız açı.
Maybe switch to view and
Aynısı değil. O şey al. Ben gerekiyor. Hayır alacaksın. Geri gel. Okay. Geri gel. Geri. Okay. Here. Not that one. Sine. Yes. You know, this we have to choose our route very clear. I have to have a little bit different shape. Top. So I give another curve. Sion has on curve, but I give another because I want to go straight rather than down.
Maybe.
Straight one goes directly to a lady.
Maybe you change the curve of the wire.
No. I mean, in view, you mean? But I see it very nicely here.
No, he meant the shape of the wire, but that's what Umar just said. He reshaped the wire.
Yeah. Yes, like this. But there are lots of side branch, of course. And if you give a curve like this, it likes to visit all side branches. Yes, please. Let's see. All right.
It seems like you have to go straight and then turn.
That's right.
Maybe change wires, either a Xeon black or a Suha wire.
But it's matter of fine route. You know, Xeon black will help me a lot because that's all hydrophilic will go easy side branches. This please, yes. If it is, I don't know. Let's see. Still not. You see, lots of curve, lots of side branches. I have small curve now here. Need to have curve. At least I can go here. Okay, I like to have another one because this curve doesn't looks like we'll go to this still.
We're going to stick to Xeon.
Yes, please. Let's see. To damage except the collateral. Yeah, I have to change it. Let's see. I can have it here. You know, filter FC. Filter FC also good. I can use it as a CTO wire. Once I have a distal cap, I can use it retrogradely.
Umar, we'll go ahead and move on to the talk.
Yes, yes. I had my time. Please go.
Flora store every. Yeah, we'll come back and you show us all the stored images.
Come back. Thank you very much.
So our next speaker is Dr. Javed Ahmed from UK, who's going to show interesting cases of intravascular imaging. We saw him yesterday. Dr. Ahmed, please go ahead and take over.
Thank you, Asad, and I'm most grateful to Park Live and their course director to invite me for participation in the Park Live. And I'm just going to go and share my screen in a minute.
We're kind of running behind time, so you have maybe around 9 minutes according to this.
That's fine, and I'm just trying to share my screen actually. Give me 1 second. Here we go. No.
Okay, we can see your screen now.
Can you see the screen now?
Yes, go ahead.
Can you see it now?
We can.
David, you're sharing a photo, not a PowerPoint.
Sorry. That's a bit strange. Can you see it now?
Yeah, we can see a PowerPoint now.
Right. Intravascular ultrasound obviously has become an essential adjunctive tool to PCI over the last 20 years in the cath labs. And I'm just going to concentrate on a couple of complex lesion subsets, particularly the left main, as well as the long diffuse lesions. And IVUS helps us to do some measurements of the lesion characteristics and allows determination of plaque as well as vessel morphology to assist in clinical decision. And it enables us optimal stent implantation. It is particularly in left main, diffuse disease, long lesion, instant restenosis, and calcified lens. and also useful in assessing stenosis and thrombosis. And you can actually use IVUS in pre-intervention assessment, peri-intervention assessment, and post-intervention assessment. And so far, a large number of IVUS-guided trials have shown that not only improves the procedural result, it also is translated into reduction of primary endpoints. For example, this IVUS XPL study, which randomized 1,400 patients, demonstrated far less MACE in IVUS-guided PCI compared to angiographic PCI. And similarly, this benefit of IVUS guidance are sustained in the longer term, particularly the 5-year follow-up and 1 to 5-year follow-up demonstrated that the effect was longer lasting rather than just the procedural outcome. And again, this is just a graph to show that IVUS guidance was associated with less absolute reduction in mortality compared to angiographic guidance. There are 10 randomized trials I've picked up, and that has shown, particularly in the left main stem, that the angiographic guidance, IVUS guidance compared to angiographic guidance is associated with improved outcome. And it also favored to reduce the risk of all-cause mortality and also the cardiac mortality compared to angiographic guided PCI. And this is just an example of pre and post IVUS intravascular ultrasound, where you can clearly see the cracks, and that actually helps the full expansion of the stent. And this is just another example of comparison of the several cases done recently, and this is just with OCT as well as the OFDI comparison. Here we go. So the next is a case example of 65 years old male who had 1 year earlier the LAD treated with the 3.0 millimeter drug-eluting stent at a peripheral hospital. This time the patient was admitted to the same hospital due to new symptoms, and some attempts were made to open calcified lesion in the proximal circumflex with a small balloon. And it was unsuccessful, and the patient was referred for further PCI attempts. So as you could see from the angiogram, that the ostium of the circumflex is quite severely diseased, and also it appears a bit of calcified. So I opted for upfront rotational atherectomy. There also appears that there may be some problem with the left main stem. So imaging guidance was very important here. After crossing with the rotawire, the plaque was modified with 1.5 Ver, and then we managed to create a smooth channel, and then the rotawire was exchanged with ordinary workhorse wire for a better support, and then we pre-dilated it with a 2.75 millimeter NC balloon. After pre-dilatation, a second guide wire was placed in the LAD. So this is just the IVUS run into the circumflex, and as you could see, this is how much longer I have got.
I have about 5 minutes. 5 minutes.
I can skip some of the IVUS runs, you see. And so basically, I decided to IVUS both circumflex as well as the LAD. So this is the run through the circumflex. And what we have noticed, and this is IVUS run in the LAD. I'm sure we could now see that there is some calcification as we are approaching into the left main stem. Then next, as we could see that this is the measurements of the left main stem, and the absolute measurement is coming up to 5.03. And so this is just a sort of exactly where we should be thinking of whether we should be fixing the left main stem or not. So what I decided to do, to go ahead with obviously try to fix the left main stem along with the circumflex. Of the first on the left hand side picture, and 4.0 into 16 millimeter stent was implanted into the left main in the direction of the LAD. But prior to doing that, we did implant a stent in the circumflex, which obviously as you can see, this is the stent in the circumflex here. And then now the stent on in the right hand panel is going across into the left main into the LAD, which is a 4.0 16 millimeter stent.
So about 2 minutes, 2 minutes, Dr. Ahmed.
Okay, sure, no problem. Then another wire was selected to cross a cell of the stent entering the circumflex, and 2.75 millimeter balloon was used to open the studs of the stent. And then after that, we used the technique TAP, which is T-stenting and protrusion technique, and for the proximal part of the circumflex. And at the same time, a a balloon was actually kept into the left main as well as the LAD. And then 3.5 into 15 millimeter and 3.5 into 15 millimeter, 3 into 15 millimeter ANSI balloons were inflated in the left main stem and the LAD bifurcation to do kissing. After the kissing, then I deployed another balloon, which is a short 4.5 into 8 millimeter ANSI balloon, which was applied to the left main to achieve optimal stent expansion and opposition, which is very important even after the kissing balloon to do the port to open the cell as much as you can to expand the stent. And as you could see, this is the final result with the preservation of the carina as well as a full expansion of the stent, which we confirmed on IVUS. Although IVUS takes a longer duration of the procedure, but obviously if you can achieve the maximum expansion of the stents both in the circumflex as well as into the left main, and that is translated into better outcomes even at 5 years or 10 years, you know. And so this is, as you could see, the stent is fully expanded. And this is the run of IVUS from the LAD into the left main. And I've got another case, which is an example of a long diffuse lesion, but in the constraint of the time, I won't show. And we can have some form of discussion if you like, or I can just quickly show the angiogram of the next case, whatever you prefer.
If you can just show your concluding slide, and maybe we can come back after the next presentation. If there is time, we can have a discussion then.
Okay, no problem. So this is the next case which I was going to go to. That is again an IVUS guidance PCI strategies of the long complex lesions. And I can quickly go through with the this is a 75-year-old male with accessional angina occurring with less activity that has not happened at rest, diabetes and hyperlipidemia, and stress MP has shown anterior ischemia. And this is just an example that how long the lesion is. That's where the IVUS guidance is very, very important. So we again upfronted the IVUS. And any discussion points about the TAP technique I did Do majority of our colleagues use that? Or I know DK Crash obviously got the best result for two-stent strategy.
Javed, sorry, actually they are ready in on the second case. For second case, Umar is ready. So we have to do another talk before that. So if you don't mind, we'll have to move on to the next talk and then the live case.
No problem.
Thank you.
Thank
you very much.
Thank you very much. Thank you.
Go ahead,
We
please.
can come back if there's time later.
Thank you. Thanks.
Okay. So our next speaker is Dr. Gilbert Tank. He's the director of surgical director of structural heart disease at Mount Sinai Hospital in New York, and he's going to
şey var,
give us,
sinir isteyeceğim, büyük sinir. Gerek olmayabilir gerçi de.
Bashir, are we doing the lecture? Okay.
Yeah, lecture. No, we are going to do the quick lecture because he had to go somewhere, so we had to move the talk earlier. So then we will go to the live case, please.
Okay. So Dr. Tang will talk about indication and evaluation for TAVR. Dr. Tang, please go ahead.
Thank you very much. Can you see my slides?
10 minutes. Yes, I can see your slides. We can see
well,
them.
Thanks so much for the kind invitation. Greetings from New York on the Saturday morning. Great to see that your conferences is going extremely well. Here are my disclosures. So we know that TAVR is now exceeding the number of SAVR, at least in the United States, a couple years ago. And we also know that the median age of patients getting TAVR are getting younger. You can see it from the United States data. Now, at least in the United States, TAVR is now indicated in all surgical risk categories, so from low risk all the way to extreme risks. And we now have new guidelines published in the ACC-AHA showing that for TAVR, it's actually also now class 1 indication in patients from 65 to age 80. So why is TAVR preferred over surgery? Well, of course, it's less invasive. There's really no incision, no heart-lung machine. You tend to go home in 24 to 40 hours. You're back to your full recovery after maybe a week. And the data also are quite evident. There's no difference versus surgery at 5 years in high-risk patients or intermediate patients. And at least now in low-risk patients, we know that there's no difference over 2 years. There are some trade-offs between surgery and TAVR. You can see that here. There's less paravalvular leak or conduction system issue with surgery, but there's definitely less AFib, bleeding, or renal injury with TAVR, less hospital stays, faster recovery. The question is durability now and coronary access in TAVR versus surgery. There's some initial assessment that the Jack paper suggests for heart team discussion in terms of whether the patient's appropriate for aortic valve intervention. You can see here. And there's also some indications for surgery still. You can see that here, patients are younger with bicuspid aortic valve, hostile anatomy, and if they have concomitant coronary disease or multivalvular disease needing intervention. So I think I break it down to 5 different points on how do you consider between surgery versus TAVR. The first is the anatomy. Can you do transfemoral? Can you achieve like a surgical-like perfect result? What about paravalvular leak or conduction system disorder? Coronary access is getting more important now with younger patients. And finally, the lifetime management. So let's talk about anatomy. We all do a CT scan. This is an EKG 4D CT scan, look at anatomy, annular and LVOT calcification, the leaflet calcification. We look at the aortic root anatomy to make sure there's no risk of coronary obstruction. And we also look at the access to make sure transfemoral approach is straightforward. If you look at the paravalvular leak, the question is, we really rarely now see moderate or severe, but what about mild? So you can see the partner 3 data here. At 2 years, there's still around 26% of patients with mild paravalvular leak versus surgery is really none. And if you look at the SAPIEN 3 Ultra, the latest generation balloon expandable valve, the mild paravalvular leak certainly is less, at least in the real-life registry compared to the SAPIEN 3. So that's definitely an improvement. With the Evolut Pro, Pro Plus valve, you can see that the number of PVL is still around 27% for mild. So we don't know the long-term implication of these patients. Conduction system disorder, we know that if you have new left bundle branch stroke, it's not a good thing. You can see that it leads to high mortality or sudden cardiac death, less LV recovery, and more permanent pacemakers. And what we can do as operators is reduce the implant depth, so make it implant a little higher to avoid the septal impingement. Pacemaker is also not benign. It can potentially impact mortality and rehospitalization. We know that patient right bundle branch block is the highest risk, but also we can try to implant the valve higher to avoid interacting with the conduction system. And you can see that here in the partner 3 low risk trial, the new left bundle branch block, you can see is still around 24–25%. And if you look at the 2-year outcomes for the Evolut low risk trial, the pacemaker rate is 21%. Now this is all comers, so we have now reduced it significantly with optimized pro technique, but certainly it's a concern. Coronary access after TAVR is going to be a challenge. And the reason is that, number one, a lot of the interventional cardiologists do not know how to do TAVR or never seen the TAVR valve. The anatomy is highly variable. The barriers facing the coronary artery is different from surgery because you not only have the native leaflet, you have the transcatheter valve frame, and you also have the commissure facing the coronary artery. This is a JAP paper my colleagues and I at Sinai has published recently. Look at the anatomic feature and devise some procedural features that can impact on coronary access. We actually have developed an app that you can download on the Apple and Android platform. You can also go to the website to learn about coronary access, different anatomy, different catheters, and with the balloon expandable and self-expanding valve with animations as you see here. It's a very helpful resource, and it's available for free to everybody, and you can even do it offline without the internet. This is a paper we recently published on how to align TAVR valves maybe to get better coronary access. We found that with the SAPIEN 3 valve, if you crimp at different orientation, it's still pretty much the same. There's no preferential rate with the SAPIEN 3 valve, at least in our experience, to improve commissure alignment. With the Evolut valve, you can see that the C-tab, which is represent one of the commissures, is mounted 90 degrees away from the fluoroscopic marker. So what we find is that when you have the head marker facing the outer curve of the descending aorta, by doing the flush port of the delivery catheter at 3 o'clock instead of 12 o'clock, meaning away from you, and you can deploy the Evolut valve at the time of deployment at the annulus, either facing you in the cusp overlap view or in the outer curve at the classic LAO view. And you can see that when you release the valve, you get good commissure alignment. This is confirmed by the CT scan of this particular patient. And what you're looking for is the C-tab at the inner curve of the ascending aorta. And you can see this particular patient coronary angiography selectively is quite straightforward. So finally, what about lifetime management or aortic valve disease? Can we re-intervene with TAVR and TAVR? So there are some trade-offs between what procedure you should have first. Is it TAVR or surgery? And you can see these are the benefits or trade-off in this particular paper. And it depends really on the anatomy. So for example, with this balloon expandable valve with a shorter stent frame, it's not feasible for everyone. You can see that if you have the SAPIEN 3 valve above the sinotubular junction and you have a very narrow distance between the frame where the leaflets can be pinned to the aortic root anatomy, you can obstruct the coronary flow. And this can be up to 20%. If you cannot do TAVR and TAVR, you might have to do TAVR explant. And this is a paper coming out in JACC Intervention showing that the mortality is quite significant in these patients, not just because they have high surgical risk, but also it's a more complex open heart operation. So what about bicuspid aortic valve? I'm just going to touch on this very briefly because you see them more in Asia. So we typically prefer surgery in younger patients if the anatomy is not favorable for TAVR and you have ascending aortic aneurysm that you need to do in surgery. And if you have high or extreme surgical risk and if your anatomy is straightforward, I think TAVR is reasonable. The reason being, look at this, the 50 shades of bicuspid valve anatomy out there. Every patient is slightly different, so you have to go by case basis. And you can see this paper from Raj McCall's group at Cedars-Sinai. If you have a calcified raphe with calcified leaflets, the chance of you dying from TAVR at 2 years is actually higher. All-cause mortality, 25%, compared to less than 10% with more favorable anatomy. And that's probably because of residual paravalvular leak or aortic root injury or coronary obstruction, and those can be very high risk. So I think in take-home messages, TAVR is indicated for everyone with suitable anatomy, but if you have high-risk anatomy, I still think surgery has a role in these patients because it's durability, and also you can set yourself up for valve in valve later on. if you have severe prosthesis-patient mismatch, meaning the valve is too small for the patient, you should consider surgery because you can always put a larger valve, because TAVR, you can only put in the largest valve possible for that given anatomy. And finally, in low-risk bicuspid patients with hostile anatomy, I do think surgery should still be preferred over TAVR. So I'd like to thank you very much for your attention and thank you for the invitation.
Dr. Tank, thank you so much for a wonderful talk and for staying on time. You finished well within 9 minutes. Thank you again for that. We have a whole bunch of questions, but unfortunately, we have a live case ready to go. They've been waiting for us to go. So we'll have to skip questions at this time, but thank you so much again.
Thank you. Good luck the meeting.
Bye. Have a nice weekend.
I think Dr. Tang will be probably leaving, so maybe a couple of questions quickly we can ask. I think he has to go somewhere, so if anyone has any quick questions, we can do that.
Well, I have a question. Dr. Tang, are you still there?
Yes.
Okay. So in younger patient, when you talk about lifetime management and if you're starting with surgery, in your practice, do you just put in a bioprosthetic valve or do you put in a metallic valve?
It depends on the age group and the patient's preference. So if they can take Coumadin and if they age, I think less than maybe even 60, we would recommend mechanical valve because durability. But most patients do not like to take Coumadin because of their lifestyle. So we would counsel them that if you get a bioprosthetic valve now, they'll likely need to have surgery later on, because even if you do TAVR the next time, so valving valve, the TAVR and the surgical valve, it might only last, let's say, 5 to 10 years. So if you have a 55-year-old, they'll only last them to around maybe 60, 65. They'll have TAVR then, and then let's say last for another 5, 10 years. So they may be like in the 70s. If they're still alive, they will likely need another intervention that will probably be surgery. So what we try to talk to them is to see which is the most realistic option to try to minimize the number of open heart surgeries. And it's really a case-by-case discussion. We also have an expert in our center on Ross procedure, which you know is the aortic valve substitute directly from the pulmonic valve, and that we've seen that to be very durable in expert hands, and is, can even outlast mechanical valves in terms of outcomes in randomized trials. So we would actually counsel those patients for that if they have suitable anatomy.
Dr. Asad Khan has a question. Please go.
Hi, Dr. Tang. Amazing talk. It's Asad here. So just one question. As you presented, most of the US data on bicuspid valve is by Raj Makar's group, and it's all with Sapien. In Pakistan, we are mainly using core valve. And what's your experience with using core valve in bicuspid? And do you think in certain anatomies we should go ahead with it if we feel that it should be able to seal the valve and there isn't much in the chance of aortic root injury and stuff?
Yeah, it's great to see you doing so well in Pakistan. And thank you for the invitation. So with bicuspid valve, so you saw that there has been some data on bicuspid anatomy with the self-expanding Evolut platform, not just from the TVT registry, but also from the low-risk bicuspid data. At least in 1 year, the data actually is excellent. The one thing we have to look at is the raphe, the type 1 raphe, in terms of how calcified it is, because remember the Evolut platform is a nitinol-based platform that conforms to anatomy. So you think you have a good seal, I would certainly think that that's a very reasonable option. But however, if the anatomy has a lot of annular or LVOT calcium, I don't think you can get a perfect result with potentially either valve because of the risk of paravalvular leak. The reason for higher pacemaker rate in bicuspid valve, I want to tell everyone, is because the septal length is typically shorter in bicuspid anatomy. So even if you implant very high to avoid the conduction system issue, it might still be a risk of conduction system issue. So and we typically do implant the valve in bicuspid anatomy higher. And of course, you saw the data. The other concern I have for bicuspid in lower risk and younger patients is the risk of stroke. Actually, it's pretty uniform now in all the data out there. Whichever valve you use, the risk of stroke in bicuspid is higher, probably because of the calcium burden. Now, that has not been studied using like a cerebral protection, embolic protection device, but certainly that's something I would be very cautious against if you can have surgery and it's low risk. I think because you remove the aortic valve entirely, that might be a better option than doing a higher risk TAVR.
Okay, thank you. Thank you very much. I think we'll move on. We really appreciate giving this talk that early from New York. Thanks a lot. Okay, sir, please go ahead.
Umar, can you hear us? We're back with you.
Thank you very much for coming us again. Now I'll show you where are we, and then. So, as you remember, we tried to go. No, come back. We tried to go searching for septal, so for epicardial collateral. Come back, please. Yes. Now, with the fielder FC, we were able to geri gel şeye kadar. Geri gel. Yes. We left it from here. It wasn't easy. There are lots of side branches. There are lots of things there, but this one is fielder FC, and it crossed that tortuous epicardial collateral. Next, please.
Any reason for choosing the fielder FC?
I have two reasons for that. First of all, Sion is more stiff than fielder FC. And second, I can use fielder FC for distal cap penetration and to go up. Sometimes we could, cross all the lesion with fielder FC when we do retrograde. So I like to use fielder FC if I need it. So as you see, I push my microcatheter, which is very smoothly crossed. This is a fine cross, 1.8 French. And after that, I had Gaia second, which was on my table. Next, please. And this is Gaia second, the proximal and distal wire are in different plane. But I think we should trust more retrograde wire than antegrade wire. Next, please. First, we like to do, yes, here. First, we like to do reverse cut. To do that, we did inflation of 2.5. Next, please.
So you didn't switch to a ping pong guide at this stage, put a second guide in?
We did, after cross, we did. This is 2.50 for reverse cut. Next, please. We
So
try a little bit to go, the antegrade wire place, but it's always two different plane, right? I couldn't went to antegrade wire place, and maybe I tried 2-3 minutes, but then I like to trust my retrograde wire, because antegrade wire somehow wasn't good. Next, please. And then I accepted this discrepancy. Now we did, of course, proximal reverse cut again. Next, please. And I like to very close to balloon here. This wire is now concave, right? Concave, yes.
Omar, can I ask, is your retrograde wire subintimal, or is it in the true lumen?
I'm not sure. Now I will tell us, but I like to trust more retrograde wire than antegrade wire, because antegrade wire is totally blind, and retrogradely it's more easy to stay intravasal, I believe.
How about guideline-based re-entry?
Yeah, we did IVUS because I like to make sure 100% where am I, and IVUS shows me. Önceki şeyi göstersene kaydı. Please look at it, the IVUS. Evet. And IVUS shows me there are two wires. You see, now I'm 100% sure I'm the true lumen at the proximal LAD. This is very nice to see. Next, please. And then I sent another EBU, and I try to engage to send my retrograde wire in this second EBU. It takes time, maybe. I think we spend. Geri gel. Ne yapıyorsun? Geçişleri göstermen gerekiyor. So in here, yes, this is second EBU. It takes maybe 5 to 6 minutes, right, to cross it. Wasn't easy. And we just try to engage the left main, and then after some time, we were successful to insert wire. Anyway, next, please. Yeah, we did it.
You can even snare it if it is difficulty in getting in.
That's true, but sometimes snare is not easy too. As you know, it takes 5 minutes, 15 minutes sometimes, at least in my hand. So, but you are right, Anyway, we trap retrograde wire now to push my retrograde fine cross, and I push that. Now I'm in the distal tip of the guiding. You see that I'm now in the guiding. Then I change my wire to RGE, and I did 2.5 dilatation. This is 2.530. And now I am ready for IVOS. I like to see IVOS, the two aim. The first, I like to see my Y course, if it is intima or subintima. Somehow I think it's subintima. But more importantly, I like to see the size of the distal LAD.
So why didn't you do IVUS before doing the balloon inflations?
I don't think it will not cross easily. Even I did balloon dilatation. It's not easy.
I think a couple of points for the beginners. He confirmed that his retrograde wire was intraluminal before he crossed the left main. If you don't do that, you can go subintimal in the left main and shut it off. That can be very high risk. Another option at that time is guideliner-based re-entry. Also, if you're using epicardial collaterals from the left, if you use the same guide, there can be a lot of tension on the whole heart, and you can cause ischemia and pressure injury, and that's why he switched at this point to a second guide and use the ping pong guide technique.
Which is the problem. So it's really calcified lesion. So I like to dilate also by trio after 2.5.
So Umar, rather than putting externalizing the wire, was there an option using the microcatheter tip-in technique and then just working on the antegrade wire?
Yes. Good option, for sure. Go up 10, 14, 16. Down. We have calcification that part, right? Down.
Can we see the main fluoro screen? We're just seeing the IVUS still image on our monitor.
Sorry, say again?
We are not seeing the fluoro images. They're on the side. We're just seeing IVUS.
Okay. Fluorayı büyük yere alın arkadaşlar. IVUS küçük yerde olacak. So, what do you want to do? Do you want to put proximal stent first or distal stent?
I think I would personally prefer to put in distal stent first, just so that I don't have trouble going through this previous stent. Although in your hands, I think you'll be able to do it either way. One advantage would be that you won't extend your dissections, and you might have a better idea of, and maybe perhaps avoid too much stenting if you start with
Please see
proximal.
the IVUS now. Thank you very much. This is 2.5, around 2.5. Yes. Yeah. Almost. Yeah. Here is almost 3.0. I'm still
don't see the IVUS on the main screen.
Okay, so
Mind putting
please
it up?
show the IVUS main screen, please. I'll pull back. Okay, now I'm pulling back again. Okay, I'm very distal. This is looks 3.0 still. In here, still true lumen. We have some hematoma from 4 to 7. We have hematoma, I think because of the antegrade wire. But we are interluminal here. And here's very calcified part. And we break that calcium from 3 o'clock, you see? Yes. Here,
Just hold it there. That's really interesting on the IVUS. I think you've got the true lumen there at 1 o'clock, haven't you?
Yes, true. Now I'm subintimal.
Subintimal here, yeah.
Very true, my friend. Yes, it means that it's tell me antegrade wire went subintimal at the proximal, right? What do you think? Because
what's your relationship to the diagonal there?
Let's see. Very good
distal
question.
to the diagonal or proximal to it?
No, not now, but you will see it now. And now I am in true lumen. Okay, now I am, stop please. Now I am the proximal of the bifurcation. I am pushed a little bit to see where is the diagonal, if I have any trouble. AP kodlara gelsene. Record, yes, yes. Yes, here, I think diagonal comes through and you see it here, nice. I'm happy here. I have a common ostium, retrograde Y and diagonal Y. So I think I'm quite good position. What do you think?
I agree that the diagonal should be safe. It seems like
let's see. Yeah, it looks
like
like
lumen distal to the diagonal.
Okay. You know, what do you think? Shall we put first proximal stent? I like to do it.
One option would be to put your IVUS back in, and where you can see on IVUS a good distal landing zone, mark that on fluoro or cine, and then, you know, without dye, obviously, and then start distally from there and stent backwards.
I would prefer distal stent first.
Okay. So let's try to, I don't want to send the IVUS again. Do you want to send the IVUS again, guys?
Well, it's either that or you do antegrade injection, which is not a good idea either.
I don't think so. It's not a good idea. Okay, but okay. Now I'm the just junction of the collateral and LAD. If you go next, from the beginning. Let's see from the beginning. Next, please. Next. Okay, maybe this one is good. Okay, so you see the collateral, it's very
yeah, so you could use the collateral as a marker, but you'll have to inject.
I think I don't. No, I can't. Yeah, but I think it would be nice to send another wire. You see, because you know I should definitely cross that part, right? So let's send another wire with double lumen catheter.
You can see from the same cranially.
What do you think?
Yeah, I think the trick here is probably to advance your, your microcatheter that you've got already up into the F main, do a tip in, switch out, and then put a dual lumen catheter down and try and get into the diagonal.
Fine drawing. Yes, let's send another wire. Yeah.
Yeah, and I guess once you have a wire in the diagonal, you can use that as a marker for your distal landing zone.
I mean, the concern here is if you stent, because I still haven't really worked out in my mind where you are in relationship to that diagonal, but if you stent AD,
Okay, so that's a good idea. So you'll just do distal injection and not worry about extending the proximal dissection. So.
Yes, yes.
Okay, nice. So
very nice.
I think I can. You see, I have to use this exactly, and I know now where should I stand, right? It's not that distal. Maybe I could do some ballooning if I need it. Obviously, I will not stand there. BHW. And we have now BHW for you know, I like to use always extra spot wire when I change, you know, any CTO wire. So now we insert in BHW. We have to have this exactly the same, and we shouldn't lose the data. So yeah, okay, it's crossed easily. I think here is the, I don't know, you don't see my reference image, but it's exactly this level. Am I right?
Yes, yes. There is good, okay. We
So-
can remove. No, no. This one.
Okay. Now I protect.
You pull your guide back so that there's no injury.
Very good.
Yes.
Excellent.
More.
Little bit.
Yes.
Yes. So.
We can do some injection here.
Yeah. So let's do some tip injection from the collateral. We have lots of clever guy around me. A little bit more distal maybe. Maybe here, right? Okay. Let's go up here. Okay. All right.
This is a 3.0 or a 275?
3.0, yeah.
3.0. Down. You went a little bit down, I guess. But I pick over that.
I understand on the podium there's Nadeem Hayat Malik and Sajid Dhakam. Do you guys have any feedback? Any tips on what to do?
I don't know, but you know, we can discuss. Maybe you can guide people about the use of septal collaterals versus epicardial collaterals, or the use of this microcatheter. Which one is everybody has different choice. Which one is safer, or which one has a higher probability of crossing through the tortuous septals. So they can be, everybody can have a different approach, but, maybe you can enlighten us about use of different devices for retrograde, crossing.
Okay, sir. Do you have any? Okay. Kashif, you?
Is that question for Umar or for me?
Yeah, anyone can answer, either you or Umar.
I guess as far as safety, clearly the safest retrograde option is to go through a vein graft and then septal and finally epicardial, which are really, they recommend that you should only attempt an epicardial once you've done at least 50 retrograde cases. That's the recommendation, because the epicardial is a lot more fragile and the risk of injury and perforation is much higher. Plus with epicardial, they nearly always tamponade, whereas septals a lot of times they're not serious complications. So just to keep that in mind, and especially with tortuous epicardial, it's safer to go with softer wire. The softest one available is the SU03 from Asahi. I think it's like 0.3 gram tip, but the body is really soft. And you also want low profile, flexible microcatheter. Maybe something like either a Caravelle or a Turnpike LP for epicardial collaterals. For septal collaterals, I think different operators have their different preferences. You can use any. Does that answer?
And what about the choice of microcatheter? Because sometimes microcatheters, they sometimes don't cross, and you have to use various support devices or even Guidezilla to get it through. So what choice of microcatheters would, in your personal preference, or any of the other, operators here, Fahim or Sohail Khan? I mean, what choice of microcatheters you have?
I think since you talked about difficulty crossing, so right from the beginning you need to have very supportive guides in there. And that's very key in retrograde cases, that you have aggressive supportive guides. So preferably an AL 0.75 in the right and XP or EBU large size in the left system. Plus 7 and 8 French guides give more support than 6 French guide. So that would be another reason for using. And then, as you said, you can either have a guide liner or maybe even a trap liner if that's available, because that can help you with trapping as well as with providing extra support. I think for septal collaterals, the Corsair, Turnpike, they both work very well. I think there's a new one by, I think it's by Boston, the Mamba, and that's kind of like a combination or a hybrid between Caravelle and a Corsair. So more pushability and more talkability, but at the same time lower profile than a Corsair. Those would be the options for septal collaterals.
Umar, we have 10 minutes left, so I guess we will be just finishing this case.
So we will do more post-dilatation. Also, what do you think for diagonal sacral exam?
Well, we saw on your IVUS that the diagonal ostium was not that disease, so maybe just have a provisional approach. My question was more about the left main. Do you think you'll be able to spare the left main? Is there enough ostial or proximal landing area before the left main, or you'll have to stent up to the left main?
Next up. So we have some disease part of the ostium of the LAD. It's almost separate ostium. I think LAD ostium is not that bad.
I mean, you've got the IVUS on the table. You could think about just assessing that on IVUS if you need to. I just wonder if you ought to put do a pot here and then put a wire into the diagonal.
Yes, very good idea, Suhail. You know, I will do IVUS anyway because to see the result and how much I could go. Let's do IVUS and to decide. But how about diagonal?
I think you should do. I think you should do a pot here and then try and wire the diagonal.
Okay, let's do first IVUS because I like to see exactly which size I have to use for pot or post dilatation. Let's do some IVUS.
Dr. Goktigan, we have 7 minutes of transmission left.
Okay.
What size balloon are you using for pots?
I like to use for the proximal, I like to use for O if it is possible. Let's see what IVUS says. Otherwise, I will do exactly what I do.
First and then assess.
I will do exactly what I do. 3O and 3.5 for post dilatation of the stent. Epicranial. IVUS'u büyük gösterelim. Hadi tutar mısınız? Bir saniye. Çok kalabilir miyim? Okay, better.
Omar, are you going to post-dilate the whole stent?
Sorry?
Are you going to post-dilate? Looks like a little bit underexpanded throughout the whole entire length of the stent.
Of course, I will post-dilate everywhere. We do it yani, all stent should be post-dilate in my practice. So we will do it, but I like to see the size of the balloon, post-dilatation balloon.
The stent is 3 and it's definitely under.
distal is, 3O, right? Do you agree with that? So it's big, big LAD.
Yeah.
So if I come a little bit back, this is 3O. I don't think I have edge dissection. If you look carefully, I don't think we have dissection here, edge dissection.
I think if there's no disease involving the ostium of the LAD, you can leave it well alone. And
okay, I'll pull back now. Please record it.
Well, the angiogram is suggestive of probably at least moderate osteal LAD disease. But let's see what the IVUS shows.
So I should definitely do post-dilatation, my friend. Yeah.
I think that's an important point, that all stents should be post-dilated. That sometimes simple fact is conveniently ignored by a lot of operators.
Especially, this is long balloons, right? Long balloons, especially, we have to do. It's mandatory.
I think that's where IVUS guidance is very important immediately after stent insertion.
In here, this is the calcified part.
I'm not sure you necessarily have to IVUS after deployment. I usually post-dilate the heck out of it and then IVUS, because almost all stents need to be post-dilated.
I mean, I think at some point you need to do the imaging.
It's that expanded valve. You see that?
Yeah, and that's not a surprise. I mean, you will need to post-dilate it.
And here we can go easily for all, right? So proximal, we do short for balloon. I have some plaque. It's 3 o'clock, but it's fine. I don't want to put another stent here. What do you think? Let's see the ostium.
I think the lumen doesn't look too bad, actually. It is almost more than 6 millimeters square, the lumen.
I think the plaque burden is considerable in the proximal vessel. I mean, if you want to future-proof this intervention, I would lean towards stenting all the way back.
Yeah, and I think the ostium of the circle is pretty okay. So
sooner or later he'll be back. He's relatively not that old.
To be honest with you, I truly agree with you, because we will implant it here, big stents, right? We will put 3.5 and I will expand it for all. Risk of restenosis is very low here. I think I will follow your advice. What do you think?
I agree, stenting up to the left main.
I think it's almost a 4O vessel, so I will go with the 4O stent in the ostium.
And he's going to be on DAPT anyway, so the extra length is not going to be a huge risk to him if it's well expanded. He takes DAPT. It's up to you whether you extend it.
You see that? Yes. And also you see that I have a good plaque burden at the edge of the proximal stent, proximal part. So that's also, to me, kind of risk for restenosis. Okay, but we have to size it, right, first?
So just to reinforce what Omar just said, so in ideal world, you would want less than 50% plaque burden at both ends of the stent. So.
Okay.
So remove this wire and working as one guide.
3,500 alayım. I will 3,20, okay. I will post that and see, yes?
Dr. Omar, we are unfortunately out of time.
Okay.
It's Asad, you can conclude and then we can move on to the next session, please.
Sure.
Omar, outstanding. I mean, you just shown how skilled you are and your knowledge of all the equipment and techniques. It's truly outstanding. You're one of the world's greatest CTO operators, and you've shown it over here. I think a great learning opportunity for all of us. I'd like to thank the panel. I think everybody's input was really constructive and useful, and I think it did help Umar a lot. So thank you very much, and it was a great opportunity.
So, Asad, thank you very much for your comment. I think what I learned from this case myself, since the time limitation, I couldn't see collateral well before the case. Number one, I think lesson I have, we have to see previous image very detailedly. We have to see where is retrograde comes from. This is number one lesson. We have to spend some time for that. And also, more importantly, we have to trust our tip injection. My tip injection shows nothing, right? But I still try to do something. I shouldn't do that. I knew I shouldn't do that, but I did it. I did it in live transmission. I don't know how I did it, but I did it. So I think we have to trust tip injection. That's
You have a
important.
great team. You have a good team, Omar.
Yeah, that's true. But I trained them.
Omar, you also pulled back the RG3, which you shouldn't do.
True. That's true. But I told them, Ahmed Shakir, he heard that, but he blamed someone. But that's also important. We shouldn't lose tip of the retrograde wire.
I think
Otherwise we lose.
Well done.
Omar,
Thank you very much.
Omar, this is Bashir. Thank you very much. I know we are supposed to do 2 cases, but I think this case is probably more than 3-4 cases. So we learned so much just from 1 case. Thank you so much. We all, I think it was grateful.
Next year, hopefully we meet in Pakistan.
Inshallah. Inshallah. Okay, thanks.
Inshallah.
Bye.
Very happy. Thank you very much.
Bashir, if I can add one last comment, I think this case was also an example that CTOs should not be done by single operators, and there should be 2 operators present to help each other out.
Yeah. Okay.
So we'll end the session, and Bashir, I'll hand it to you.
Thank you. Thank you, Hassan. Thank you, everyone.